Hello everyone, and welcome to today's lab talk. My name is Yatish Patni from Diagnostics, and it's my pleasure to introduce Dr. Michael Hubank from the Royal Marsden Hospital in London, and he will be presenting today's topic, FGFR3 testing in bladder cancer. So to quickly outline the agenda, I'll begin by playing a short video introducing Diagnostics and our precision medicine platform, DXRX. After that, I'll introduce Dr. Hubank, who will guide us through the topic of FGFR testing in bladder cancer. We will have some time for a Q&A session at the end, and I encourage you to submit questions throughout the presentation by typing them into the Q&A box at the top of your screen. So to begin with a short video introduction to Diagnostics and our DXRX platform.
Welcome to this DXRX Lab Talk, hosted by Diagnostics. Diagnostics provides end-to-end solutions for the launch of precision medicine diagnostics. Using our platform, DXRX, the diagnostic network, we place labs at the forefront of developments in the precision medicine landscape. Our mission is better testing, better treatment. We believe that labs need to be involved earlier in the precision medicine decision-making process. We promote partnership and education to drive precision medicine, and the work of laboratories remains central to this mission. DXRX membership is free of charge and provides access to our aggregated datasets, the latest reports, publications, and lab talk recordings, and ensures you're the first to hear about scientific studies and DXRX collaborations, such as EQA programs, grants, and global ring studies. Since 2020, we have executed over 30 collaborations covering a range of purposes, some of which have resulted in publications or posters at major conferences. Visit dxrx.io to learn more and register for upcoming lab talks and collaborations.
So to introduce Dr. Hubank, Dr. Hubank has over 20 years of experience in genomics. After completing his PhD at UCL, he held positions at the University of Sussex and Yale University before returning to UCL's Institute of Child Health in 2000 to establish and lead UCL Genomics. In 2016, he transitioned into clinical diagnostics at the Royal Marsden Hospital, where he heads a translational lab focused on developing genomic assays for cancer diagnostics. Since 2018, he has served as the scientific director of the NHS England North Thames Genomic Laboratory Hub. We are thrilled to have you here with us today, Dr. Hubank. The floor is yours.
Thank you very much, Yatish. That was a nice introduction. Sorry about your video. I expect people can find out about Diagnostics through other methods in the future. So I'm going to tell you a little bit today about the testing that we've done. First of all, hello to everybody across the region. We in the North Thames Genomic Laboratory Hub in London cover a region of about 8 million people, and do all the cancer testing for that region. And for those of you who don't know, we work to a national test directory, which has been agreed across England, which for bladder cancer includes FGFR2 and FGFR3 testing as standard of care. And I'll refer to that on and off during the talk. But I'm also happy to answer any specific questions about that as we go along. I'm just trying to figure out how I move the slides. There we go. Just a few disclaimers here. So we work with lots of different pharma companies. I'm not biased to or for any individual ones, but obviously doing the testing, lots of pharma companies are interested in what we do. And actually we work together with them to ensure that the testing that we do here covers the kind of targets that all the different pharma companies are going to need, because that just makes sense. Rather than having to do many different tests, we try to combine all our tests into one, which then is much more efficient to deliver. But again, I can talk about that a little bit later. But today we're going to focus as much as possible on the bladder cancer and the testing. And the environment around how we do that testing, the cancer itself, what the stages are, why we would do the testing, how we would do the testing, and how you handle and interpret the results that come out of that testing. So, as I say, my background is I'm a molecular biologist, but I've obviously worked quite a lot in cancer over the last 20 years. But I'm not going to claim I'm not an oncologist, and I'm not a hardcore histopathologist. But it's important to integrate all of those skills, and we work very closely with our oncologists and our histopathologists in order to deliver the testing and the service that we do here in London. And by doing that, of course, it's important to understand to some extent the problems and issues that some of our colleagues are facing. And that helps us put together an overall service that works as well as possible. So in bladder cancer, we do a reasonable amount of testing for bladder cancer, but certainly not a large amount. And I think that's something, again, we can discuss later. It's something we're trying to encourage people to ask for more. I think a lot of it depends on the pathways. But in particular, because bladder cancer has a high incidence globally. We're looking at hundreds of thousands of cases every year, and up to 250,000 ensuing deaths per year from bladder cancer. Slightly more likely to develop in men than in women. But it's the point of the slide here is really trying to illustrate that this is a relatively common type of cancer, but there are now potential actionable treatments that we can find, and the molecular diagnostics that we can do will help both with staging diagnostics and hopefully with treatment options as well. As you'll see as we go through the slides, some of the slides are very detailed. And that's so that you can review those slides at a later date. If I tried to go through every point on every slide, we would be here for a lot longer than an hour. So I'm not going to try and do that. I'm certainly not going to read all the slides out, but there's lots of information on these which hopefully you'll find useful and you can come back to afterwards. The other thing to say about bladder cancer is not only is it a relatively highly incident cancer globally, it's also increasing now. That could be for a number of different reasons, but particularly in the Western Pacific region, that area is likely to see perhaps the relatively largest increase in cases over the coming years. Possibly, that we're looking at longer life expectancy, changes in dietary habits. There are a number of different potential causes of that. But it's something that it's important to be aware of and to prepare for, and that's something that we're certainly doing in the UK is to prepare for increased load for diagnostics that we're expecting from bladder cancer. So I'm just checking. So we're on to bladder cancer biology and genomics. Do let me know if the slides aren't changing as they appear to be for me. So there are lots of different stages of bladder cancer. There's I think that the characteristics. So that one of the things we are faced with is that there are a number of different staging and grading categorization methods currently in circulation, which can perhaps be a little bit confusing. I think at the moment the most important thing to be aware of is that the newer system really is looking at high grade, low grade, and the earlier stage, the papillary urothelial malignancies of low malignancy potential. So clearly, as you're going from one end of this pathway to one end of this journey to the other, we're getting more invasive types of cancer. We're looking at stages at the beginning where there is less and later there's more. However, there are common mutations across the bladder cancer, and we'll go into how that might change a little bit with the different major subtypes as we go through. It's complicated, so there's no direct, it's not a completely black and white, say that you don't have a particular set of mutations at one stage and the different ones later. And of course, you have a range of different variations as well. We're going to focus on FGFR mutations because of their actionability, but some of the other variations that we see in terms of copy number changes, chromosomal rearrangements, and then mutations in genes like P53, PIK3CA, HRAS, HER2 copy number changes, and also expression of different genes in different types of cancer can help us understand where we're at with that cancer, what stage it's at, what type it's at, and how it's likely to respond to treatments. The expression of those and the changes can be characteristic for different subtypes, and those subtypes being the non-muscle invasive bladder cancer, which is about 80% of diagnosed bladder cancer, and those are stages, as you can see, TIS, TA, and T1, and then the muscle invasive bladder cancer, which is about 20%, which is stage 2A to T4 under the current categorizations. Now, in terms of genomics, if we try and separate those categories out into the non-muscle invasive and the muscle invasive, there's clearly overlap in the diagnostic patterns across those two. However, there are some characterizations that we use now to fully characterize the tissue that we have in front of us in the pathology lab, and we can look at that in a number of different ways. We can look at signatures, and by signatures, what I mean is characteristic patterns either of genetic mutations across the genome, for example, an ApoBec signature, as you can see in the class 2 non-invasive cancers, or in either of them, in fact, either of the class 2s, or also gene expression changes. So we're looking at gene or protein expression as well. So there's a number of different pathological characteristics that we can look at, which helps with diagnosis and staging. And then on top of those, we can also look at mutations, which are going to hopefully specifically help not just with the diagnosis and staging, but with the treatment options. And the one that stands out obviously there is the FGFR3, which again you're likely to see across a range of different bladder cancers. But do come back to this for future reference. Why FGFR? What's special about fibroblast growth factor receptors? Well, they're involved in quite a lot of different types of cancer. We found this is an oncogene. This is a gene which promotes growth and cell division. Typically, normally it's activated by fibroblast growth factors. So you need a combination of the growth factor and the receptor to activate the cell cycle in the receiving cell. There is then a feedback control mechanism which will then shut off FGFR when it's not being activated by its cognate FGF. And what happens in oncogenesis is that regulatory loop is disrupted in some cases, and there are various different methods by which that dysregulation can occur, and those are typically point mutations or rearrangements, or sometimes copy number changes, or sometimes deletions, and the combined or the effect of those genomic changes are to either constitutively activate FGFR 2 or 3, by which I mean that they no longer need to be triggered by the FGFs, the fibroblast growth factors, and instead of having that properly controlled cell division process, they just divide all the time. They're constitutively activated, and another way of permanent activation is to lose the regulatory zone. So there are subtypes of mutations in FGF which disrupt, for example, the last exon, and in the last exon there's a regulatory domain. If that's no longer there, once the FGF has been activated, it can no longer inactivate and which means that it'll carry on constitutively being switched on, sending that cell division signal. So the point I think I'm making here, rather than going through all of those, is to say, look, there are a number of different molecular changes we can detect at the DNA or the RNA level, or by other methodologies we'll talk about later. But there's a lot of different changes there, and sometimes some of the traditional approaches that we've used in the past, the PCRs and the FISHs, while they have their uses, cannot always detect all the different types of variants that could be triggering constitutive activation of FGF. And if we've got constitutive activation of FGFR, that can be driving the cancer. And that's obviously very important because there are now targeted inhibitors of FGFR which will switch off that process. And that's what we're trying to find. FGFR3 is particularly associated with bladder cancer. And as I said, on the test directory in England now, we test for all the different types of mutations I just showed by DNA and RNA-based methodologies for FGFR2 and FGFR3, but it's FGFR3, particularly in bladder cancer, where we tend to have a higher implication for an increased risk. Why is FGFR3 rather than FGFR2? Not really sure, to be honest with you. I think it could be due to more accessibility, high levels of expression. Maybe it's involved in particular substages of early development in bladder cancer, particularly in but for whatever reason, these are the mutations we tend to find at higher levels, whatever the exact mechanisms are. And as I said before, do come back to this slide for more information. So what's the clinical utility? Well, as I said, FGFR3 is very common in bladder cancers. Up to 80% of the early stage TA cancers have activating point mutations in FGFR. It's slightly less common in stages 2 and above. But many bladder cancers, even without FGFR point mutations, will show some sort of involvement of FGFR3, and that can again be indicative of a driver role for FGFR3. So the key thing here is again to emphasize, because we know that FGFR3 is a driver in bladder cancer, because we know it's involved early on, which means that we can test primary tissue, even in metastatic cases, because the idea is that it's already there driving. Then the more comprehensive testing we can do, assuming that actionability is possible, the better, if you want a good chance of finding an actionable FGFR mutation in a patient with bladder cancer. And it is quite likely. And I think that the other thing to note here, for example, some of you may be more used to looking at things like FGFR2 in cholangiocarcinoma and liver type cancers, where we often generally see fusion events driving the cancer, typically. In the bladder cancers, it's more often the point mutations. It's not exclusively so, but it just means that there's a wider range of mutations we really do need to screen for. So it isn't sufficient just to look for fusions in FGFR2 and FGFR3 in bladder cancer. You really must look for the point mutations as well. Otherwise, you'll be missing the majority of the likely drivers in those cancers. So why are we doing this? We're doing this so we can use targeted precision therapy. And this means that instead of saying, okay, well, many of our patients are probably going to have this mutation, let's just treat all of them. The problem is that these drugs are expensive, and I know that in the sort of East Pacific and Western Pacific regions, there are different reimbursement methodologies. In England, of course, we have the health service, and we are allowed to test for this but only on the basis that what is found is then actionable. There's no point in doing a test if you're not going to action what's found. But depending on what the mechanism of reimbursement is, you're always going to want, presumably, to make that as efficient as possible. So you really want to be testing patients where you're going to know. So you're going to be giving the drug to patients where you know it's going to work, and in order to do that, the precision testing that we're discussing today is going to help with that. So instead of just knowing that only some of your patients respond, you do the test and know that if you're going to give them an expensive drug, that patient is very likely to respond. Whereas if they're negative for their variants, that they're very unlikely to respond. And that's the key take-home message of this slide. So where does that fit into the diagnostic pathway? We have, I think, nationally in England, but I'm sure this works out certainly across most countries now. A fairly standard pathway for pathological testing of bladder cancers. The sample obviously needs to be collected, requested by either the primary care doctor or pathologist. Samples are taken in the histology lab, and those samples are then stained and assessed for oncogenicity. And then that sample can then be, once we know that there is a cancer there, once we know that is cancer and that it is worthy of further investigation, either the oncologist or the pathologist can then request the follow-up testing to do the sort of things that we've just described that will allow that precision diagnostics to then go ahead. Now, depending on what test is then ordered, you'll get a different range of potential outcomes from that test. So it could be quite, if it's an IHC test or a FISH test, it can be relatively quick. If it's a large gene panel, it might take a little bit longer. But the flip side of that is that you get comprehensive results as opposed to a very, maybe a very limited result set. So typically in very urgent cases, in England, we would perhaps lean towards some of the faster tests and sacrifice the comprehensiveness, because if it's going to be too slow for the patient to survive, but this is more common in lung cancer, we would do a very rapid test. But wherever possible, and I would say that over 95% of the tests we do, we accept a slightly longer turnaround time, assuming that the patient, that will still be clinically relevant for the patient. But because that gives us a comprehensive result, it covers all the different variants we're likely to find, we favour that type of test. It means you do the test once, you find everything you're likely to find. Yes, it takes a couple of days longer, but it gives you a higher chance of actionability should you be able to find that. And we have had sad situations in the past where some of the more rapid tests have been performed. We've not found anything. We've then subsequently carried out a comprehensive test, found an actionable variant, but then that was too late for the patient. So we're trying to get away from sequential testing and favour comprehensive, rapid. That's the first test you do is a comprehensive large test. May take a couple of days longer, but it makes more sense in the long run, both for the patient and also for the healthcare system. And then obviously the result of that then needs to be discussed, and we'll come on to that shortly. And so this is it. So once you've done your test, you're going to get a report. The report should give a good description of what has been tested, exactly how that test has been performed, what the limitations and strengths of that test are, and what the potential actionability that has been discovered. So it should state, a good report will state whether the patient is positive or negative for an FGFR2 actionable mutation, plus obviously report any other important diagnostic findings that has been found. And equally, it should report where the sample quality perhaps wasn't good enough, for whatever reason. If the test has failed, that should be made very clear as well. That test will then be sent on to the pathologist usually, and back to the oncologist, and that then may go to a multidisciplinary team for discussion. So obviously we may find what the lab would consider an actionable variant, but we don't know who the patient is. We don't know what the other circumstances are of the patient, and so the responsibility for actually actioning what we found lies clearly with the multidisciplinary team. Typically, it's not always necessary in England now. In an individual oncologist can action a report we've got if they're confident enough to do that. But in general, we would recommend it goes to an MDT to be interpreted in the right context of the circumstances of that particular patient, because obviously we want to make sure that the appropriate medical procedures are then followed subsequently. So that then clearly needs a close involvement of pathologists to make sure that everything is done properly, and that really also means that test. So it's all very well for us to get the test results, send them off to the oncologist, but that we need to be sure that those results are reliable and representative, and that means that the pathologists and the surgeons in some cases need to take appropriate samples and sufficient quantities of samples. We'll come on to that in a minute, and that those need to be then processed appropriately, not overstained, not overfixed. Too much fixation will impede the molecular processes downstream, so we prefer not too little formalin fixation, not too much formalin fixation, just the Goldilocks zone of the right amount. And there are guidelines available to say exactly what the best way of doing that is. So formalin fixation is not a problem for molecular testing if it's done properly, but it does need to be done properly. And then clearly we need to know all the other information about that tumour from the pathologist's perspective before the tests are ordered, and then we carry those out and then return those results. So I'm not going to talk too much about this. This isn't my area, but obviously there are a number of different ways samples can be taken. This lies in the realms of surgery and pathology. The TURB is the one that is typically performed for bladder cancer, but we can perform tests from other material as well. The key thing from the lab perspective is that we get sufficient quantity of material, and I'll come on to how much I mean in a minute, and that it is as far as possible tumor material, that we know how much of the material that we've got is tumor, because when we sequence what we've got, we just sequence everything that's in there. And so if a lot of that material isn't tumor, that gets sequenced as well, and it kind of dilutes down the signal that we get. So this upfront point of taking the right sample from the right place, assessing what's in there, giving us an idea of how much of the sample we've got is tumor, whether any of it's necrotic. All of those things are very useful in terms of generating a confidence in the reports that we are then subsequently going to send out. In terms of how much, I mean, obviously, we'd always say, well, as much as is reasonably possible, but typically we would in our lab actually use something like 5-10 micron sections for a large DNA panel, and another 5-10 micron sections for an RNA panel per patient, and that really wouldn't matter whether it's primary or metastatic. It's important also to say, I think, that that for bladder cancer, whichever material you get is worth testing. So long as you get, we'll always try in our lab, we'll always try to get a result out. As long as we know the information, so we know what the limitations are. We can always try, because if we get a positive result is always a positive result. A negative result, however, we do need to interpret, so we need to have as much information as possible so that we know that if it's a negative result, it's really a negative result, or well, we weren't able to take very much material, it was a fine needle biopsy and we only had 30 cells in there, and then we can say, well, we didn't find anything, but it could be because there simply wasn't enough material. Can we have another sample? So that's really the important thing about this slide. Again, not going through the whole details of it. It's about trying to get enough material, but if you can't, try anyway, but make sure we know what the limitations of that test are, so that if the result is negative, that's interpretable. And that's often the challenge in diagnostics, is to interpret that negative result confidently to say, yes, this patient definitely does not have an FGFR3 mutation. So again, I think in terms of what's going to happen to the patient from the path lab, yes, all that information is very important for the rest of the medical pathway. From a lab perspective, to some extent, we don't really mind. It doesn't really matter how the tumor is staged to do the test. We can still do the test, right? It doesn't matter which category it comes in, and that feeds back to this idea that some countries have follow different pathways and guidelines than others. It doesn't matter for the lab, because at the end of the day, DNA is DNA. The key thing here is that we are testing patients. The key thing from our perspective is that we have enough material, we know what's in it, and hopefully the result would be actual, were we to find a positive result. I think those are the things to bear in mind when you make the decision to do these tests. So I think this kind of just tells us what we're looking for when we've done that. So you can then request particular biomarkers, or you can request comprehensive tests. I think the thing to remember at this point is that what you're really looking for at this point, the most major actionable variant here is the FGFR2 and FGFR3. So make sure that the request doesn't cover FGFR2 and FGFR3, and that's covering not just point mutations, but also fusions and copy number changes. So it's very important to know what your test is actually testing, and that fine, there are lots of different methods to take that sample. There are lots of different tests that could be done at the end of it, but make sure they're testing for the variants you want in the genes that you want. And that's why I'll just say a little bit more about those types of tests and how those work. So again, this comes on to, again, this is a little bit more about sampling. And depending on whether you've got primary or metastatic material, the numbers on here I'm not going to go into, but really this is just breaking down typically how many samples are taken, what you expect of that material. What we've moved to very much in England is to try, as I said, to avoid sequential testing and using up the tissue, because often the tissue can be a limiting factor. And so we'd rather have the tissue that we get in, hopefully, as I said, in a reasonable condition, then to be tested on a large gene panel where we're comprehensively testing all the different things we can possibly find, full-length genes for FGFR2 and FGFR3. So this is one of the disadvantages of PCR. PCR will just look for the hotspots, and if that's all you can find and you need the result quickly, please do that. And we would certainly do that in our lab. But what we prefer is to have sufficient material and sufficient time, as I say, approximately 2 weeks, to comprehensively sequence every variant in the full-length gene as part of a large gene panel, and also do the RNA as well. Preferred biopsy methodologies, as again, there are optimal pathways for taking the samples. There are optimal pathways for preparing the tissue for then sequencing or follow-up testing down the line, making sure that you've got enough material to do the PD-L1 testing as well. So remember, the molecular testing goes alongside the diagnostic testing, and there's a little bit of competition there for the material. So it's about trying to optimize best uses of that tissue to make sure that we both get an accurate diagnosis, but there's enough material left at the end to do the test that you require for precision therapies. So in terms of which technology, so we know that there are a number of methodologies out there, and traditionally over the past, we've obviously used FISH and PCR, and that they're still fine. So we still use FISH and PCR in the lab, but you need to be aware of the limitations. So obviously with FISH, we're looking for chromosomal level changes, maybe copy number changes, rearrangements. With PCR, we're looking for individual point mutations. But the limitation of those is that you can only see the resolution that those tests will perform, and the resolution of FISH is quite broad and across the whole chromosome. And the resolution of PCR is very specific, so you're looking for either very specific fusion or mutation or very specific copy number change, perhaps. Whereas again, with sequencing with NGS, you can look at a much more comprehensive view of that gene. You can see every variant in that gene. So sometimes we'll find a variant of unknown significance, and we may not act on that. We may find a new variant in FGFR2, FGFR3, but at least that variant could be discussed in an MDT. And for example, we've had circumstances where a new variant has been discovered. There's been a more recent publication. It might not be in the current guidelines specifically, but an assessment would be made that, yes, there's sufficient evidence now that this new variant we've discovered, which isn't potentially in the guidelines, actually the MDT makes the decision that that is an actionable variant based on more recent current research, which has very recently been published. And that happens all the time. And that's a great advantage, again, of doing the comprehensive testing, because you're not limited specifically to any given subset of variants. You have that option to look for more variants as well. So that's really what we focus on here. We can detect all those different types of variants. And as I just reinforce that point, it's important to know that the test you're requesting will cover all the variants which might potentially be actionable, and preferably all in one go. The sequencing way we do it, so the way we do it in our lab, we extract DNA and RNA from those 10 micron sections. We then carry out an amplification of those, and then in our case, we put those on a 200 gene panel. We only report what's relevant for FGFR2 in bladder cancer, FGFR3 and FGFR2 in bladder cancer. But we have the option of carrying out clinical trial work, for example, if new targets come along, because we've already sequenced the rest of that. Why do we do a 200 gene panel? Because we run this alongside all the other tests that we do. So we may only have 3 or 4 bladder cancer cases a week, but we might have 30 or 40 lung cancers and metastatic colon cancer. All of those things go together because it just makes it much more efficient. And we run it on a NovaSeq 6000. We do 2,500 tests a month at the moment, and that's increasing every month. It just makes this thing a lot more efficient. So it might sound it's counterintuitive, but sequencing a 200 gene panel in our lab at the economy of scale that we've got is quicker and cheaper. It's actually cheaper than doing individual PCR tests, because we have one workflow, we have the staff focused on that workflow, and that gives us the results we want, and we have a lot of other benefits from that too. Yes, you have to then analyze that. So we have a clinical scientists team that will analyze those data, find the known point mutations or fusions, find the candidates, and then report those and advise, and then that obviously then goes on to the MDT. So the disadvantage, as we said, they're longer turnaround time, and it does require some complex bioinformatics. So make sure that if you're going to either do this, that you have that capability, or that if you're sending these tests to a lab, making sure that they have the ability and capability to report this kind of complex variant. RNA much better for fusions, DNA much better for the point mutations and amplifications. That's it in a nutshell. And the RNA being because we don't tend to capture the introns in these genes. And if we don't capture the introns, you can't find a breakpoint. Sometimes the introns can be very big, and that we will miss the breakpoint if we try to sequence the DNA from, we try to look for fusions in DNA. We can do it for some genes, but it's much better to do it for RNA, which is already spliced, so we can look to see where those breakpoints are in RNA much more easy. So try and always remember that if you're looking for fusions, you need an RNA test, and if you're looking for DNA point mutations, you need a DNA panel test. FISH is fine though in some circumstances, and I certainly wouldn't say, if you're not able, or if you need a more rapid result, I would say don't do it. But just bear in mind, it's not. I would not say that FISH is standard procedure for us now. It would not be how we would do this test nowadays. It's more labor consuming, time consuming. It can't detect a range of the variants which are actionable, whereas the sequencing methods can. And similarly for PCR again. Nothing, you can't beat PCR for sensitivity, and if you've got a very, very vanishingly small amount of material and it's not going to work on a sequencing methodology, then the best thing you could do is probably a PCR for the hotspot mutations, and we would do that. But we would then note that if it was a negative, it's not really a negative. It's a negative just for the variants that we've tested for. And we would still advise, where possible, to do a more comprehensive test to make sure we've covered all the other possible variables. So I think I'm going to come to an end. I think now we've got quite a lot. It'd be good to leave some little time for discussion. So just as a summary, then, FGFR2 alterations play a pivotal role in development and progression of bladder cancer. Bladder cancer journey, as we've seen, is quite complex. And the discussion of the context of any variants we find is important. Identifying patients who will most benefit from FGF-targeted therapy requires reliable and comprehensive molecular profiling, and the choice of tests may depend on the critical context, available resources, and the specific FGFR3 alterations of interest. So with that, I think I'll hand over back to Yetish for any questions that you may have.
Thank you, Dr. Hubank, for an excellent and very informative presentation. We'll now move on to the Q&A session. And just a quick reminder to all attendees, please submit your questions into the Q&A box, and I will read them out to Dr. Hubank. Just to get started, I do have a couple of questions. So to begin, in your presentation, you shared that comprehensive molecular testing is key to identifying patients who might benefit from FGFR3 targeted therapies. In your opinion, which molecular testing method is best suited for detection? And is there any challenges with false negatives or positives using archival samples?
Good question. So first of all, archival samples shouldn't be a problem, and particularly, that can be very important, for example, in metastatic cases or where it's difficult to take a subsequent biopsy. To go back to the archival sample should be okay, and we would probably recommend that you do that. So it's not always necessary. I mean, obviously, we would in some cases prefer to have a newer sample because that will describe the tumor as it is now, and that clearly has benefits. But because we know that FGFR3 can frequently be an early event, it's likely to be there in the archival material in the first sample that was taken. And so if you don't have that result from from a previous, if that test hasn't been performed already on that patient and that the archival material is all that's available, please do that test on that material. There's a very good chance that if the FGFR3 variant is there, we would detect it from that. The only exceptions would be if the material has not been fixed properly. But then you probably wouldn't know that unless you try. So I would urge that would be the case. In terms of which is the best methodologies to do, I mean, I think I'm quite categorically clear on this. We use a large gene panel. So you need a gene panel. It doesn't have to be a 200 gene panel like ours, but it needs to be a gene panel that comprehensively covers the full length sequence for the DNA and the RNA for FGFR2 and FGFR3. And I think that to me is the barest minimum of what I would like to see on a gene panel. And likely you're going to have a gene panel that covers much more than that. But that's really what the bare minimum would be. Yes, I would recommend a sequencing based approach for the reasons we discussed before in terms of comprehensiveness. And for RNA, and yes, I would also say make sure that you do both DNA and RNA test. If you want to cover as you should want to cover the fusions as well as the DNA point mutations. So where ideally NGS on a gene panel with DNA and RNA, and whether it's an archival sample or not shouldn't really matter if you're going to get that comprehensive result out. Only if you don't have enough material, the material is very limiting, or the turnaround time is very pressing, would I resort to one of the other methodologies.
Thank you. We do have some questions coming in. So is there any recommended non-invasive testing methods based on urine or blood for FGFR3 testing?
Oh, very good question. Yeah. So yes, particularly, and this is of interest to me a lot. Actually, we're looking to develop a lot more liquid biopsy based testing here in the UK. We've actually got what we call a circulating biomarkers network activated now in England, where we're looking at deriving the evidence that we can cost effectively deliver liquid biopsy based testing. So first of all, to answer the question from a technical perspective, yes, you can do this, and yes, it should work. Particularly from blood, and in bladder cancer, I think urine testing has been demonstrated to be effective or relatively effective. The problem I think at the moment is we don't have enough sufficient evidence to know in what circumstance you would do that, what the reliability of it is, because the thing is, we know that tissue testing, that's the standard care approach. To replace that with liquid biopsies, we need to generate the evidence that you've got the right test. The test covers what you need. The test can be delivered by the centres that need to deliver it. That there's clinical evidence that from a clinical trial or something that liquid biopsy testing is effective in that particular indication. So we're working very hard, I think, in England now, not just us, across the world, to generate that evidence. I think most people would still say that tissue testing is king, as it were, and that's what you do if you could. But I think that will change in the future. I do believe in the future we will move to a liquid biopsy approach. I just don't think we're quite there yet. But we would certainly use it in some circumstances. We're certainly using it now, or moving to use it now as standard of care in lung cancer, where we want rapid turnaround. We want to cut out all of that histological pathway because we just need to get a result, boom, like this. Perhaps it's not quite so pressing in the bladder cancer, but yes, it is possible. Yes, the panels, for example, we run a panel from what do we call a tech transfer from a company called Garden Health, which is how we run that particular panel in a house in our lab. But there are a number of different ways that's done. So I think that's really exciting for the future. Sort of, it's getting there. I don't think it's standard of care particularly anywhere, but it can certainly be done. And the results, if you find a positive, are absolutely actionable. Absolutely. The problem here is always, how do you deal with a negative? If you get a negative from a blood test, is it really negative, or have you just not got enough circulating DNA in that sample to be able to get a result? So that's really what we're grappling with in terms of going live, if you like, with that nationally here.
Thank you for that. What are the current testing gaps in bladder cancer, and what are your recommendations to ensure eligible patients do not miss out on targeted therapies?
Yeah, so I think I'll go back to what I said right at the beginning. So I think we test probably less than half the number of cases I think that there probably are in our region. And there's a number of reasons, I think, for that. I think sometimes, that there's a lack of awareness that this testing is available, and that the actionability of this is really quite effective. And I think that's an important factor that we need to make oncologists, clinical professionals more aware. Sometimes it's the pathways hard to there isn't the option to test, or people don't know how to put those pathways in place. Sometimes I think that the pathways, even though they're in place, might be a little bit clumsy, and that might put off some clinicians ordering tests, because by the time they get the test result back, it's too late. So I think a lot of the problem is really logistical. Some of it, of course, is down to pathways and what the indicated treatment pathway is for those patients, because there's no point in doing a test if you can't action it. If you're just going to give the patients standard chemotherapy anyway, regardless of what the test result is, if I find an FGFR3 mutation, then you're going to give chemo anyway, and only chemo, then it's questionable what the value of that might be to some patients and clinicians. I would argue that actually it's still beneficial, because we find a range of variants which will confirm or sometimes change classification and staging. So I think this is down to more awareness and just trying to get out to the community out there that this is a valuable, very valuable, and potentially hugely beneficial for the patients. Patients on these drugs. I know that patients. I've had reports back from oncologists who have told me that even though I'm in the lab, that we do get some feedback. It's nice to know that some patients do so well when they get these targeted therapies that we found that they wouldn't have got a few years ago. So it's very important, I think, that we try and spread the word, I think, and where there are problems in pathways, we identify those and do our best to fix them, to make sure that patients are getting the testing they need. The other thing I think is just improving practice in path labs, so that the fixation methodologies are fine, so we don't get failures. So there's a combination of things, I think, that lead to lack of optimal testing. And I think if we all work together on that, we can make sure that our patients really benefit from this, exciting new therapies.
So would you recommend testing all patients for FGFR3 genetic alterations?
I think I would, yeah. I mean, so long as you can put your hand on your heart and say, if I find an FGFR3 mutation in this patient, I'm going to action it. I think that's the bottom line of this, is that you need to look at the circumstances and say, would I action the result that I found? And if you would, then you should test them, because we know. And sometimes, I mean, the other question is sometimes, okay, fine, you might test early, find a variant, and say, well, yeah, but the standard pathway is such and such, and I'm only going to use this information down the line. And then that becomes a question of, is that cost effective? I guess that's something which you then have to have a discussion with, your your reimbursers at what stage they will actually fund the test that you want to perform. As I say, in England, the criteria are that what you'll do will be actionable. So preemptive testing probably wouldn't be covered in the UK, but it may be in other regions. I mean, obviously I'm slightly biased. I'm guy in the lab doing the testing, and we believe that it's a valuable thing to do in all circumstances. It certainly won't hurt, and I guess it really comes down to reimbursement.
Okay, next question. Testing for FGFR3 at diagnosis is recommended with newly collected samples. Do you recommend new sample collection at the metastatic setting or the use of archive tissue?
So I think, I mean, I would generally say the use of archive tissue, because it's difficult. If if that material is if there's a pathway to collect the new tissue, if it's affordable, if it can feed into the lab, then it is good to have newer tissue because of the it's a better description of what's happening right now. But for FGFR3, as I've said before, the variant is very likely to already be there at the earlier stage. And I wouldn't want people to think that, oh, well, we have to have a fresh sample, so we're not going to, and we haven't got one, or it's a really poor sample, so we're not going to do the test. Absolutely don't think that way. Do certainly send the archival tissue. The only drawback with the archival tissue is if it's particularly old and it's not been fixed very well. But I would urge that it's certainly perfectly feasible to use that in these circumstances. There are other types of cancer, for example, breast cancer. If you're looking for ESR1 in breast cancer, where that won't be there in the primary material, it's an acquired resistance or developmental tumor developmental mutation, and that you must have a later biopsy or blood test, a blood-based test for that. But that's not the case here. Here, you should be fine to use the archival material.
Okay, thank you. Do you have any suggestions to improve MDT collaborations for optimal testing and reporting? And can you tell us about your experience?
Yeah, I have to say, I mean, it's important to have the right blend of people at the MDT. I think that's the critical thing. You need to have clinical scientists there, I think, really, who could properly interpret the result, because even, I'm a molecular biologist. My job is to develop the tests and make sure we cover everything that we need. But in terms of interpreting that any particular variant, particularly, if you're finding something, and it's very difficult. If let's say we do the whole sequencing, we find a variant in FGFR3, which isn't one of the hotspot mutations. Now, every oncologist is going to look at that and say, "Oh, but there's a mutation in FGFR3. This must be actionable." And so you need to have a blend of people there who can actually tell you whether they think that's the case or not, present the evidence, whether that is or not. Because it could be true. It could be that, yes, actually, there's a reasonably good chance that this variant is actionable, that the MDT can make a decision to action based on this new variant. But unless you have the expertise in the room, it's not going to be something which is possible to do. You need pathologists. You need a pathologist really there, and obviously you need an oncologist and people who know what the pathway is. So I think, yeah, my recommendation really is just to have the right people in the room, have it done on a regular basis, so that the people who participate in the MDTs learn and get experience from doing so. And that's certainly something we've benefited from hugely, since we've been doing this in our particular lab. Just having in our GNH, Genomic Laboratory Hub, the more people participating in these things, the more they understand how it works, and the more productive those are. Because particularly if you're going to, we may have a lot of cases going through, so you need to make decisions quite quickly. You can't really spend hours on every case, and so you want somebody who recognises, yep, we've seen this before. Yep, and the clinician says, oh yeah, and this patient is perfectly able to receive this. They've been through this protocol, or no, we can't give it this because they've already had the other one. So just have the right people in the room and get them experienced, and that way it can be very. And I love going to MDTs. It's really, I learn so much from the oncologists, and they learn a lot from the clinical scientists, and it's actually a very it's a self-fulfilling thing that it gets better the more you go to.
Great. And then I think this might be the last question. how many what is a percentage of bladder cancer? What percentage of bladder cancer is caused by FGFR3 mutations, if you know?
Oh, I think that's in the slides, isn't it? I think we've got, I think it's something like, well, caused by is a challenging one, isn't it? Because I'm not entirely sure that it's necessarily the case that an FGFR3 mutation is causing, but it probably usually is driving. I mean, it's quite a high, I think, didn't we say it was like 80% of TAs of that early stage? So, you know, it's well worth it. This isn't like, for example, NTRK. This isn't like you know, NTRK where 1% of your cases are going to end up positive. You're going to get a reasonably high positive rate of FGFR mutations in bladder cancer, and there's a good chance that that's a driver. I'm not going to give you a specific because I don't have the numbers exactly in front of me, but you can read the slides.
Okay, thank you. I think that's it for the questions. And just before we finish, I'd greatly appreciate it if you could take a moment to complete a feedback survey. The link has been shared in the chat and all attendees should have access to it. We've hosted many lab talks and want to ensure that they continue to provide value to our attendees. So your feedback is really important to us and will help us improve. It would be great if you could all just take a moment now to click on the link in the chat and fill it out. And finally, I'd like to just extend a big thank you to Dr. Hubank for being with us today and delivering such an insightful presentation. I'd also like to thank you all for attending and engaging with this session. And I look forward to seeing you at future events. I hope you enjoy the rest of your day and thank you again for joining us today. Goodbye, everyone.